our faculty for today is Dr. Varun Pushkarna. He is the senior consultant in internal medicine in the Fortis Escorts Hospital, Amritsar. And his area of interests are rheumatology, hematology, and cardiology.
So we understand that anemia is the most common clinical problem in the, in our field of medicine. Now, the questions are asked about your approach to the diagnosis of anemia. So the most important part, I reckon all of you are preparing for MRCP part 1 right now.
Yes.
Yeah. So in part 1, the onus is basically on how to reach to a diagnosis and what are the investigations required, what is the patient presentation, what are the keywords that are there that you have to pick up to understand that what examiner is trying to ask from you regarding the diagnosis. So as far as the treatment part is concerned, it is more of a concern in MRCP part 2 exam, be it written or be it basis. So in part 1, they want to know if you understand the pathophysiology of the disease, the biochemistry of the disease, the relatable pharmacology of the disease, and whatever investigations that you might require along with statistical data. So that interpretation, that amount of data is given to you to interpret in the question. So a physiological approach to the diagnosis of anemia requires a very, very efficient path to diagnose it and then manage it. So not all anemias are iron deficiency anemias, and not all macrocytic anemias are vitamin B12 deficiency anemia. So we have to see the anemias in a holistic way and then try to arrive at what we are dealing with and how we are going to manage it. So anemias basically occur because either the RBC production is inadequate at the level of bone marrow. Then we need to understand what is required to produce an RBC. One RBC would require production of hemoglobin. So that means heme is required, globin is required, and in heme, porphyrins are required and iron is required. And then the whole structure to be brought together and put into an RBC, the bone marrow, it will require vitamin B12 and folic acid for proper maturation of the RBCs to arrive at a point where they become anucleated and a fully developed RBC to carry hemoglobin. This is one reason. The other reason could be the shortened lifespan of an RBC, be it because of a direct attack by an organism like infection, like parasitemia, like malaria, or immune-mediated hemolysis. Hemolysis is a term used to define whenever we are talking about destruction of the RBCs. So either it is an antibody-mediated hemolysis, or it is an organism-mediated hemolysis, or wherever we do not find such a pattern, there is an organ-mediated hemolysis, that is spleen-mediated hemolysis. So anemia will occur, one, when there is not enough production, second, when there is more than required destruction. So let's begin right away without much ado. Which are the anemias where the production is deficient, the production is not up to the mark? So they are called hypoproliferative anemias. Now these anemias are the most common anemias encountered in the clinical practice. So when you see an RBC, it looks almost normal. And the reticulocyte index is low. So what is reticulocyte index? Reticulocyte index is, the reticulocyte is basically an immature RBC. Sometimes it can have nucleus also, or it is a large RBC. It is yet not matured enough to become a proper red blood cell. So it is called a reticulocyte, the junior RBC. So that reticulocyte index is low. Now, reticulocyte index tells us that bone marrow is making sufficient amount of RBCs. If it is making sufficient amount of baby RBCs, then of course the adult RBCs would be also, to the same tune. So when we call it a hypoproliferative anemia, that means we are trying to say that the bone marrow is not synthesizing enough blood cells, so the reticulocyte index is low. This happens whenever there is a marrow damage. Now, marrow damage can occur because of infiltrative diseases. They can occur because of in novo, de novo malignancies. They can happen because of metastasis into the bone marrow. Very much early into the iron deficiency, when the size of the RBC is not affected, at that point of time, also you can have hypoproliferative anemia like picture. Third and not the least is whenever there is a erythropoietin deficiency. Now, erythropoietin we know is basically a hormone secreted by the kidney to stimulate the RBC production at the bone marrow level. Now, whenever either the erythropoietin synthesis is deficient or the bone marrow has become resistant to erythropoietin by any reason, the bone marrow will not produce sufficient RBC. Please, if you please, there's a lot of noise coming in. So let's see the marrow damage. So the marrow damage can occur because of either the infiltration of the marrow by a tumor or fibrosis. Now, fibrosis is interesting because sometimes there is a condition defined as myelofibrosis in which there have been enough damage of the bone marrow that eventually there is a scar tissue formed in the bone marrow material, and hence the fibrosis occurs. Now, there happens that the normal erythroid precursors, they are crowded out by fibrosis or other cells that have invaded into the bone marrow. So tumor or fibrosis that infiltrates the marrow may originate in the marrow, like in leukemia or myelofibrosis, or it can come from outside, like metastatic cancer or myelophthisis. Sometimes, rarely, as we shall discuss in the class, yet to come, aplastic anemia can happen, which can be because it's a kind of myelodysplastic syndrome, aplastic anemia, wherever there is exposure to drugs, radiation, chemicals, some sort of viruses, autoimmune mechanisms, all of them can play a combined factor leading to depression of RBC production at the level of bone marrow, leading to hypoproliferative anemia. Most of those cases are idiopathic. We haven't found the reason. And then comes iron deficiency. Now, early iron deficiency produces hypoproliferative anemia or iron deficient erythropoiesis. There is a decrease in the serum ferritin levels less than 15. There is an elevated iron binding capacity. The serum iron levels are low. The iron saturation is low, but it is not, below 10%. So we can actually say that this is early iron deficiency. When the deficiency is less than 10%, then we call it proper iron deficiency anemia. Sometimes we do get iron deficiency anemia picture with an iron saturation of more than 50%. In those cases, basically it is a defect of iron to be inculcated to make hemoglobin. So that is called sideroblastic anemia that we will see again. All right. And then comes a hypoproliferative anemia due to erythropoietin deficiency. Either there is inadequate production of erythropoietin, or there is the renal disease, or there is inadequate erythropoietin action. Can anyone tell me where do you see inadequate erythropoietin action? So erythropoietin ban raha hai, it is being manufactured by the kidney. Bone marrow is healthy, it is intact. So it should produce good amount of RBCs. But then where do we see inadequate erythropoietin action or erythropoietin resistance? In which condition?
Sir, CKD.
In CKD, you have decreased renal production of erythropoietin.
Sir, iron deficiency anemia?
Yes. So you will see iron deficiency anemia in this patient. In chronic iron deficiency, we will see microcytic hypochromic picture. So this was very, very clear about that. HB being 8.1, hematocrit 24% with MCV of 70. We are dealing with a microcytic type of a picture. So this is iron deficiency anemia. All right. So the next question, it is about a 25-year-old young girl who presents to the clinic with difficulty in swallowing for past 6 months. So this patient has dysphagia. What does she have? Dysphagia. So the opening statement is a young female with dysphagia. She also reports fatigue, lethargy, shortness of breath on minimal activity, looks like anemic. She reports craving for ice. What is craving for ice known as? What is this known as? This is called pica. So pica means abnormal taste, abnormal eating habits. So she's been craving for ice since past 2 months. Physical exam reveals pallor, tachycardia. Remainder examination is unremarkable, but hemoglobin is 6.8 with the MCV of only 61 and RBC count of 3.8. The patient has a family history of beta thalassemia. What is the likely cause of her difficulty in swallowing? Very interesting question. So first tell me, what kind of anemia do we have here? So she has severe anemia. This is one. Anything else?
Sir, thalassemia.
So you said thalassemia. Why did you say thalassemia? Why it cannot be iron deficiency anemia?
Sir, as you said in the previous slides, MCV divided by RBC count. Over here, it is coming like 16 point something. So it's more than 13.
Yeah.
So yeah, it will be IDA. Sorry, sir.
All right. So it is more than 13. Very well approach. Very nice approach. Actually, this is what you needed to have. Absolutely correct. I can discount you on the answer part. That's okay. But the approach is absolutely correct. So in this patient, you would actually calculate the Menzel's index. And if the Menzel index is more than 13, you are fairly okay that this patient is that you are dealing with has iron deficiency anemia. Now you tell me, is there any association of a young female with dysphagia and iron deficiency anemia? Any syndrome that rings the bell? Ever heard of Plummer-Vinson syndrome?
Yes, sir.
So there is a web in the esophagus, upper esophagus, that leads to dysphagia. Along with that, there is iron deficiency anemia. So the answer here is, all right.
Okay.
C is the answer, iron deficiency anemia. So as you correctly followed the approach, so this is a classical association of iron deficiency with Plummer-Vinson syndrome. This patient has low HB, fine, history of pica, fine, and difficulty in swallowing. So in this particular patient, your Menzel index comes out to be 16.05, which points out to iron deficiency anemia. Had it been less than 13, we would have thought about thalassemia trait running in the family being the culprit. All right. And beta thalassemia minor does not present with Plummer-Vinson syndrome. So that is another one. All right. So now we quickly rush to megaloblastic anemia. So when I say megaloblastic anemia, I only mean that these are the RBCs which have not found maturity. They are the RBCs which still continue to be immature. So they are large RBCs which are called megaloblasts, and you can find them in the bone marrow. This condition occurs due to impaired DNA synthesis, which does not let nuclear division to happen properly. So cytoplasmic maturation, which is mainly dependent on RNA and protein synthesis, it can continue to happen. So the cells become large in size because cytoplasm maturation continues to happen. Okay. So pernicious anemia is an autoimmune disorder whereby there are antibodies against the Castle's intrinsic factor damage. So let us say there are complements roaming about to kill the RBC, but the RBC is protected by these CD55 and CD59. They do not allow these to attack the RBC and destroy it. So let us say there has a mutation that has happened which leads to absence of CD55 and CD59 on the RBC. So the RBC becomes prone to be attacked by the complement pathway and being killed. So these anchors, they usually protect the RBC from a complement damage because DAF inhibits C3 convertase, which is almost the final conversion in the complement mediated pathway. So there occurs destruction of RBCs on a complement mediated pathway. Ultimately, the terminal attack complex formation happens and it leads to paroxysmal nocturnal hemoglobinuria. But there occurs thrombosis also in these conditions.
because they lead to pancytopenia, nocturnal buildup of dark urine, and the hallmark is DVT. So they have venous thrombosis either in the legs leading to DVT or in the brain leading to CVT or cavernous venous sinus thrombosis. Although thrombosis occurs because of the the complement mediated clumping of the RBCs before hemolysis occurs, but if the hemolysis has finally happened, it will lead to hemolytic anemia and jaundice. It may lead to aplastic anemia, myelodysplasia, acute leukemia, because these are potential candidates to convert into leukemic picture. Presentation: episodic dark urine with first urine of the day caused by hemoglobin presence in the urine, hemolytic anemia, pallor, fatigue, tachycardia, jaundice, and hematuria. Thrombocytopenia leading to mucosal bleeding, petechiae, ecchymosis, leukemia leading to infections and thrombosis, and finally renal impairment. Evaluation is by flow cytometry, which is the most accurate test that the RBCs do not have CD55 and CD59. So they are nude RBCs. They are not wearing a jacket of CD55 and 59. Labs will obviously show anemia, thrombocytopenia, and leukopenia. So the treatment is amazing. There is a eculizumab. Now the eculizumab, as we just discussed, that these RBCs are destroyed by complement mediated pathways. So the best thing is to treat them with something which does not let the complement get activated. So it is eculizumab is a recombinant humanized monoclonal antibody against complement protein C5. Now C5 is inactivated. C5 acts at the last stage of the complement cascade, and if you block the C5, that means you block the complement mediated hemolysis. But this complement is also important to protect us from capsulated organisms. So that means you should treat a patient who is on eculizumab as if you are treating a patient who has had a splenectomy done. So you must vaccinate all the patients against Neisseria and pneumococcus due to increased risk. The treatment would be allogenic bone marrow transplant. So give them a new DNA based RBCs who can produce more, erythroblasts who can produce more RBCs of the normal nature. Supportive therapy is folic acid and transfusions as and when required. And definitely there is an improved prognosis with eculizumab. So a 42-year-old man presents to primary care physician with complaints of fatigue and occasionally dark urine over the past 3 months. He has had dark Coca-Cola colored urine when he has urinated at night or early in the morning. However, when he urinates during the day, it appears to be normal light yellow color. Lab is initiated and shows HB of 10.1, which is anemia, elevated LDH, which means hemolysis, platelet or cell death, cell destruction, platelet count of 1 lakh, and leukopenia. Urinalysis taken reveals brown tea-colored urine with hemoglobinuria and elevated levels of hemosiderin. Which of the following is responsible for this patient's presentation? Is it deficiency of C1 esterase inhibitor? Is it autosomal dominant deficiency of spectrin protein? Is it presence of temperature-dependent IgG autoantibody? Is it deficiency of CD55 and 59 on the RBCs? Is it an autosomal recessive deficiency of platelet GP2B3A receptor? So what is the answer here?
So 4.
Yes. So it basically means that CD55 and 59 are deficient, leading to a PNH. So it is important that you know that other answers also, that C1 esterase inhibitor deficiency leads to hereditary angioedema, which is dermatology condition. Spectrin deficiency leads to hereditary spherocytosis. We just read it today. Paroxysmal cold hemoglobinuria, PCH, is due to presence of an IgG autoantibody, that is cold agglutinin disease. Autosomal recessive of deficiency of platelet GP2B3A inhibits shows Glanzmann disorder, which is thromboasthenia, bleeding disorder, almost like ITP. Any questions you can ask? Thank you. Bye, everyone.